Now, in the second section of our topic, toxoplasmosis, we will talk about the diagnosis of toxoplasmosis. And in this section, we will talk about the toxoplasmosis in immunocompetent patients, serology and molecular diagnosis of toxoplasmosis, immunocompetent host, and ocular toxoplasmosis. Clinical manifestations of the toxoplasmosis. If intact immune system, usually the patient with a toxoplasmosis, they are asymptomatic. So the most common important thing is the immune response. If the immunity is strong or the patient is immunocompetent, then usually they are asymptomatic. Asymptomatic nature, usually the diagnosis is difficult. Features in congenitally infected children, usually they have neurological complications like hydrocephalus fluid in the brain. They have microcephaly, small head. Micro is small. So microcephaly, small head. Mental retardation and chorioretinitis. So all these are the manifestation in congenital toxoplasmosis. Severe prenatal infection, multi-organ failure, and intrauterine fetal death. So if the infection is severe in the prenatal period, if the mothers are infected, usually it can cause intrauterine fetal death. Toxoplasmosis in immunocompetent patient. Common manifestation is cervical lymphadenopathy. Cervical lymph nodes are enlarged. Nodes are non-tender, they are not tender, discrete, and they vary in the firmness. Lymphadenopathy in suboccipital or supraclavicular area. Also in the inguinal or mediastinal area. So lymphadenopathy is more common in the suboccipital or the supraclavicular area, and also in the inguinal or mediastinal areas. Generalized lymphadenopathy is present in 20 to 30% of patients who are symptomatic. Routine lab and serologic screening can be done. Evaluation of cerebrospinal fluid, polymerase chain reaction amplification of toxoplasma DNA. Rare complications are pneumonia, myocarditis, encephalopathy, pericarditis, polymyositis. So these are some rare complications. CSF of chronically infected individuals, this is normal. They have no complications or no findings in the cerebrospinal fluid. Results of routine lab studies, excellent except for minimal lymphocytosis is present, elevated ESR, which is usually in all the infections, ESR is elevated, nominal increase in the serum aminotransferase. These are some minimal findings that are present on the lab test. Other than that, it's usually the excellent. After treatment with antibodies to TNF, reactivation of latent infection or acquired infection. Individuals with AIDS, more than 90% cases due to recrudescent infection. In most cases, encephalitis develop. In immunocompromised host, disease is rapidly fatal. Opportunistic infection of central nervous system in persons with AIDS. Infection, people with AIDS seropositive for Toxoplasma Gondii, they develop encephalitis. More than 50% of the patient's intracerebral involvement, non-focal to focal dysfunction, encephalopathy, meningoencephalitis, mass lesions, seizures, motor deficit, central nervous system lesions in the brain stem and basal ganglia are present. Lesion in the pituitary gland or CMJ, panhypopituitarism or hyponatremia, cerebral toxoplasmosis differentiated from other infections, HIV-associated neurocognitive disorder. Autopsies show multi-organ involvement, respiratory involvement cause dyspnea, fever, and necrosis and mixed cellular infiltrates are present. So all these are the different findings present in patients with the toxoplasmosis. Next, the congenital toxoplasmosis. Infection of placenta cause hematogenous infection of the fetus. So from the placenta, infection spread from the mother to the babies. Neonatal hypoxia and hypoglycemia, decreased level of oxygen and glucose. Visual impairment, we mentioned chorioretinitis is very common. There is high intracranial pressure present. Infection in pregnant ladies is asymptomatic. Prenatal serologic screening is performed. Tissue and body fluid test, culturing serologic testing. PCR is done. Isolation of Toxoplasma Gondii after subinculation of sample. Isolation from biopsy tissue cysts usually we can see. Isolation from body fluid cause acute infection. Demonstrating the tachyzoid in lymph nodes and histologic demonstration. So different tests are performed. We mentioned that usually the routine lab tests, we don't have enough findings present other than lymphocytosis and increased serum alkaline transferase level. But other than that, different serological and molecular testings can be helpful, especially the specimen from the fluid and the tissues. We can find the tachyzoids present and the cysts present. Next, the differential lab diagnosis of toxoplasmosis. These are some conditions that needs to be differentiated from the toxoplasmosis. So a clinical setting, we have mononucleosis syndrome. Alternative diagnosis, we have Epstein-Barr virus infection, cytomegalovirus, HIV, Bartonella infection, and lymphoma. And the distinguishing characteristics we can find on serology and serology, PCR or culture, biopsy. Then we have congenital infection, can be in CMV, HSV, rubella, syphilis, listeriosis, and then again distinguishing characteristics can be done by culture, PCR, serology, culture. Chorioretinitis can be in tuberculosis, syphilis, histoplasmosis, and again we have culture and serology done. Chorioretinitis in AIDS patients, CMV, syphilis, herpes simplex, BCV, fungal infection, again culture and serology. CNS lesions in AIDS patients can be in lymphoma, brain abscess, progressive multifocal leukoencephalopathy, fungal infection, and mycobacterial infection. So all these are the differential diagnosis depending on the clinical presentation or clinical setting, and all these infections need to be differentiated, and by the differentiation should be by the diagnosis done by serology and by the culture and biopsy. Next is the serology, is the study on the serum. So ology is the study and the test done on the serum cause detection of presence of IgG and IgM, which is as a result of host immune response. Circulating IgA is in acute infections. Sabin-Feldman dye test and ELISA, indirect fluorescent antibody test, positive IgG titers more than 1:10 detected 2 to 3 weeks after infection. Double sandwich IgM ELISA or IgM ISAGA. Molecular diagnosis, we have approaches independent of serologic response, PCR technology, high sensitivity and specificity. So whatever results we get after serology, we do the molecular diagnosis independent of those results, and it's highly specific and sensitive. Isolates can be genotypes, obtaining polymorphic sequences. Patients with lymphadenopathy only enlargement of the lymph nodes, positive IgM titer is responsible for acute infection. Indication for therapy if clinically warranted. Serum IgM titer determined again in 3 weeks. Elevation in IgG, no rise in IgM, infection not acute. So if it's only elevation IgG, that is significant that it's not an acute infection. Borderline rise in IgG or IgM reassessed in 3 to 4 weeks. HIV infected persons tested for IgG. IgM serum antibody usually is undetectable. Focal anomalies shown by CT or MRI. Neuroradiologic examination is done. MRI shows multiple lesions. Leucovorin give to prevent BM toxicity. Brain biopsy identifies in 50 to 75% of the cases. PCR amplification of cerebrospinal fluid. In congenital infections, PCR analysis of amniotic fluid for B1 gene of Toxoplasma Gondii, serologic diagnosis, persistence of IgG or IgM titer. IgG determination repeated after 2 months. Assessment of eye and brain in congenital infection, cerebrospinal fluid evaluation, and radiologic testing. Ocular toxoplasmosis, involvement of the eyes. In that we have positive IgG titer and typical lesions are present in the eyes. Antibody production, Goldman-Whitmer coefficient. Parasitic antigen-specific polyclonal IgG assay. Parasite-specific polymerase chain reaction. Clinical diagnosis, majority supported by the lab test. So that concludes our section 2. Thank you for watching sqadia.com.